Hello and welcome to the Digital Health Hubcast, where technology and healthcare collide. I'm your host Hannah Clemmens from the South Yorkshire Digital Health Hub, where we're on a mission to tackle health inequalities by transforming the future of digital health. Digital innovation is at the heart of the future of healthcare, and on this podcast I sit down with leading experts and innovators from across the digital health landscape to discuss the biggest opportunities, toughest challenges, and how we can innovate in this space to create a healthier and more connected future. In the spotlight today are the directors of the South Yorkshire Digital Health Hub, Professor Tim Chico and Professor Steve Haake. Together we discuss why digital health, and specifically why linking different types of data, could offer new ways to deliver healthcare and support both healthcare professionals and patients to better understand and look after their health. Tim is Professor of Cardiovascular Medicine at the University of Sheffield and a consultant cardiologist at Sheffield Teaching Hospitals. His national roles include the Associate Director of the British Heart Foundation Data Science Centre, where he leads the smartphone and wearable data theme. Tim's career has spanned academia and industry across genetics, vascular biology, drug discovery, and health data science. Steve is Professor of Sports Engineering at Sheffield Hallam University. Some 2 decades ago, Steve established sports engineering as a global discipline, becoming the founding editor of its first journal and building up the world's largest academic research group in the field. Between 2019 and 2022, he was the chair of the Active Travel Advisory Board for Sheffield City Region and is chair of the Parkrun Research Board. It's a real pleasure to have you both here. Steve Haake, how are you today?
Fine, I am great. I'm really glad to be here, thank you.
Oh, amazing. And Tim Chico, how are you today?
Really good.
Really good.
Grateful to still be alive after cycling in.
Yeah, actually walking in was quite treacherous in places.
It is slippy.
I live just above the snow line, and then this is just below the snow line, kind of. Yeah, but it's now an ice line.
So we've made it.
We did.
Good. I'm really pleased. I'd love to start by defining digital health. So I'd love to know, both of you, what you mean when we say digital health.
Wow, that is a toughie. We should know, shouldn't we? We should have a stock.
Start with the hard ones.
Oh my God, what is digital health?
I'll have a stab at that.
Go on, you go first.
And what I usually say is it's a completely meaningless term because at the moment health is digital. If you email someone, if you use a mobile phone to ring your surgery, that's digital health. It's just not very good digital health. So it is the next evolution of how we access healthcare, how we deliver healthcare, how we measure the effects of healthcare, and how we use the technologies that are already existing and are being developed at an even faster rate to achieve what we want to achieve with healthcare. Now, I think at that point we get onto firmer ground, don't we, about what we want to achieve. We want better, more humane healthcare. We want better outcomes for patients. It's reasonable to want more cost-effective healthcare. So, and these are the areas that we think digital healthcare can contribute. Yeah. It's not the only answer, that's for sure.
Yeah,
I was thinking. There was a stat the other day that I read that said that 1/3 of girls born today will live to be 100 years old. And thinking, okay, so what will healthcare be like in 100 years' time when that person comes to the end of their life? And in terms of the digital nature of where we are now and where we might be then, so where we are now, if you go into a hospital, it's still quite manual in a lot of places. There's still a lot of ticking of charts. There's still people at reception. It's still quite clunky. And in terms of the number of databases there are, do you know how many there are? There's like hundreds.
Well, there's 300 or so just in a single hospital sometimes.
Yeah, and they tend not to be linked, and then so linking them together, which is part of what our digital health hub is trying to do, linking them together is quite a task. And then if you think about the patient journey, so as a patient, you might be able to go online and book an appointment somewhere, but generally it's by letter, and you might get letters after the event's happened, or you might get a letter the day before saying it's been cancelled and it's now in 3 months' time. It's all very clunky. So in 100 years' time, what you would expect is, I don't know what mobile phones will be by then, some kind of implant or something, but our mobile phones, our digital records will all be unified, will all be in one place. and you'll be able to control things a lot better, as we can do with everything else. Online shopping, it was dead easy. What's online shopping for health?
Yeah, so it's catching up with the rest of technology.
I think it's the rest of the world, to be honest.
I'm interested, Steve, in what you said about linking data sets. Can you expand on that a bit more, about what that would mean for patients, for example?
Well, for the patient, as a patient myself, and my mother's in her 80s, so taking her to places, the experience as a patient is you go in and you talk about something, say, oh no, we don't have that record because that's in a different department. So we'll have to go and find out. So it might be a phone call. They might ring someone up to say, can you look on the record and tell me what that says? Whereas you would hope that in one hospital, everything is all in one place. So, and that's kind of the nature with the way the hospitals have been developed and designed in the last few years. This kind of idea that we might have competition between hospitals has fostered the idea that that's their data, that belongs to them, but that it's not a unified NHS. And to say we have an NHS which is unified, you might as well say that business is unified. Every company is different. Every small and medium enterprise is different. Everyone does it in a different way. If they don't unify all the databases, why would you expect a hospital to do the same thing when it's been set up in the same way?
Yeah, it blows my mind a little bit, because as a patient, I would expect the NHS to know everything about me. If they need to order a test, it's easy, you just link it all up, but it sounds like that's really not the case at the moment.
Absolutely. Over 5 years, the NHS spent £1 billion just storing paper records. And we're still in a transition where we go from writing on pieces of paper to entering data into some form of computer system. I don't think any clinician or indeed patient enjoys entering data into computer systems, but it has to be the way that we make best use of the information. So once you've transitioned from paper, which can only be in one place at one time, to digital information, which can be in multiple places multiple times, it can be joined up, then you can start that process. Unfortunately, the situation's even worse, because although there's huge amounts of data on all of us within the NHS, but it's in lots of different places, it's still not all the information that patients, carers and clinicians need. For example, how physically active are you, or can you be? What do you eat? What do you do? Where are you? What's your housing like? What's your air quality like? What are your actual symptoms? What's your experience of health over the course of time? And there's none of that data within our NHS record at the moment.
Yeah, all of those things that affect someone's health. So there's various kind of models out there that will tell you the things that affect someone's health. So if you think of the population, the 100% that is the population's health, so only 20% of the population's health is defined by the quality and the access to the healthcare. That's only 20%, and that's where we put all our money. So the other 80%, about half of that is our personal behaviours, how much we drink, how much we eat, how much exercise we do, what drugs we take, our sleep patterns. And then the other 40% is things like security, education, the environment that we live in, and so on. So all those things affect your health, and yet we focus on just those one or two things that are your problem. Whether it's a poor toe or a broken leg or some kind of chronic disease. And as Tim just said, we need to link all those things together, because that other 80% is really, really important. And I don't know about, probably my best experience of digitalisation is probably primary care, so going to see your doctor, going to see your GP. If I go and see the GP, gosh, they put notes in all the time, and they've got codes for everything. So they seem pretty good at it at that front end. But I don't think it goes anywhere. It's very difficult to get that to go any further into the hospital system, I think.
No, that's absolutely right. Primary care were way ahead of other parts of the NHS in terms of digitisation. And that's been a huge success, and it needs to continue. I guess the discussion about getting all the data and linking all the data raises the question, well, why is that helpful? Is this just a kind of stamp collecting exercise? And the point about data is it's useless unless it changes a decision that the patient or the carer or the clinician actually makes. It's not helpful to know how many steps you've done unless that information leads to something that improves your health. And as a doctor, I suppose, just to peek behind the curtain, it's truly concerning and appalling sometimes how little information we have on which to make the biggest decisions. There's this thing that I really hate in medicine called the end of the bed test. People talk about the end of the bed test. To decide whether or not someone gets an operation, you stand at the end of the bed and kind of look at them and, they won't make it or they will make it. I mean, that's a terrible way to make a decision that can be absolutely momentous for the patient. And I've had many conversations with colleagues where they think that patient is housebound and shouldn't have an operation, and I think they go to bingo every Thursday because they told me they go to bingo every Thursday. And I'm not saying I was right and they're wrong, but I'm saying one of us is wrong. And so this is not about knowing everything about people, but it is about knowing more about people than we do presently in order with them to make the right decision. We know from work that colleagues of mine have done that when we measure someone's physical activity before an operation which is performed to improve their physical activity, it turns out that some of these people who the clinicians thought were very limited were doing 20,000 steps a day. And turns out they didn't do any more after an operation, of course. So these are just small examples where a small amount of additional objective information could make a difference as to whether or not someone goes to an operation that they don't need or is denied an operation that would prolong their life or improve their quality of health.
There's a nice example in the research centre to do with cancer, where they're taking people with really complex cancer conditions and measuring their fitness level. So the fitness, how fast could you walk at a specific distance? And as you get older, it gets harder and harder and harder. You become less fit. And you mean cardiovascular fitness, the efficiency of your lungs and your heart. And there's some measures that they use. And if the measures are too low, very simple measure, if they're too low, they can't have the complex operation that they need. So the intervention is, can we get them fit enough for the operation? So you do something, you get them to walk a little bit more, you do more steps, and hey presto, they can then go and have that operation which will prolong their lives. So there are very simple things that you can do. Now all that data now is in the digital health system because it's being collected, and it's quite an intense program. But that's an example of the things you can do to improve the quality of care and the quality of someone's life and extend their lives in a healthy way.
Yeah. So I think from what you're both saying is by understanding more about a person's everyday life, where they're living, what they're doing, you'll be able to make much better decisions about if something does go wrong and they need an intervention. You'll be able to have better outcomes.
Yes, partly because you know more about that individual, but also partly because you know more about the tens of thousands of similar individuals previously that you can compare them to if you have that data digitized, and so that you can aggregate it and compare an individual against that. So there's another odd phenomenon in medicine where you spend 20 years kind of trying to get competent at something, and then you retire, and that competence is just built on the cumulative number of patients that you've seen. So I'm slightly better at diagnosing a heart attack now than I was at the start of my career, because I've just seen a lot of heart attacks. And then I'll retire, and that cumulative experience, which is just embedded somewhere in my brain, will be lost, and the generation of clinicians after me will have to go through the same process of building up enough experience of what a heart attack looks like so that they can get tolerably competent at recognising it, and then that process just continues.
So in 100 years' time, when we look back and you're 203, however old you'll be then, so that makes you 103 now.
That makes you 103 now.
Sorry, I just don't come up with numbers off the top of your head. So So in 100 years' time, I would hope that with the AI models that we're starting to create now, that we could pick up your expertise in some way and do something with it. Or are we going to do that with the data? Is there a way, do you think there's a way we can get your experience as well as just the data's experience?
Oh, I mean, my experience is based on the data, some of which is in the records already, sometimes in paper records and inaccessible, often fragmented. Some of it less so, because what the patient tells you is really important, but you can't both listen and write down every word as what they say. So this is what I said earlier on about there's a lot of data that we really do need that is missing in the record at the moment. It's just kind of vanished out of the mouth of the patient into the ear of the specific clinician about, say, what was the symptoms they had, how do they describe them, etc. So once we capture all that and preserve it, then we can learn from it at a scale that's not, and we've seen this happen with large language models. Large language models are truly incredible, and the thing that made them happen was the digitization of so much written information on the internet, but across journals and books and other things. And then you can learn from that. So suddenly, instead of me learning from hundreds of patients, you could learn literally from millions of patients. And we know from large language models that turns out you're better when you do that. We know that these models outperform doctors in their in some tests, for example.
Yes, I was reading the other day that some of the models at the moment are performing very well on multiple choice tests and written tests, but when it does come to the conversations with patients, apparently they're not that good. They're only getting it right, less than half the time. So it's not even more than 50%. That's like ChatGPT 4 and the other models.
I'm sure that's right, and that's probably because those conversations, there aren't very many of them written down somewhere and digitized in order to learn from them. As I say, they're just kind of in the brains of the people who are part of that conversation. Of course, what we're talking about here is effectively recording every word said between a patient and a clinician in order to then build up a data bank of learning. And I'm not saying that's what we're doing in the Digital Health Hub, but that would be what would be required to begin to learn from what is said between those things. And something we haven't really covered so far in the conversation is, we're not digital evangelists. We're not blind to the concerns. We're not naive to the privacy and other considerations of these things. And we don't believe that digital health is the answer to everything. We know that the challenges to health are far more fundamental. So, but with that awareness, we also don't accept the status quo, right? Which is that people aren't getting the healthcare that they have a right to kind of expect, and that we could improve things with some of these approaches.
I wonder if you can expand a little bit more. You've kind of touched on some potential risks that might come with using AI, for example, or other types of digital health. So I'm wondering if you could tell me a little bit more.
Gosh. Well, okay, I'll start. Tim's nodding at me. I mean, also, there's always the privacy issue. When you're talking about people's health, there's always that concern, and certainly as a researcher at the back of my mind, what would happen if that person's data got out onto the internet? So, Mr. Smith has got this particular condition and something, would that person be happy with that? So that's always kind of the worry in your mind. So what you do is you anonymize everything as far as you can. And it's basically called pseudonymization. So, but if you get down to n equals one individual, if you have enough information about that individual, you could possibly find out who they are somewhere in the world. So there's various techniques that you use to make sure you can't have all the data all at the same time, because that is pretty unique to a person, particularly to some kind of AI bot. So you've got to be very careful about what you do with that data. So it's buried under layers and layers and layers of security generally. And to get it out as a researcher, we have to go through some pretty strict protocols. I mean, even to the extent where quite often there's just one kind of screen that you can go in and use, and you get a piece of paper and a pencil, and you can go in, you do what you think is your research, you look for whatever it is, and then someone else looks at your results and goes, right, are they allowed to have that because it's uniquely identifying that individual person? So the answer might be, sorry, you can't have that data. You need to take away one of your variables, make the data much less kind of unique, so you've got thousands of people, so then you don't know who they are. So there's the security aspect, and there's the ways around all of that, which are, people are working on day in, day out.
Yeah.
It's I mean, there is a transaction here. People already know that some big tech companies sell their data, use their data in ways that are no doubt explained somewhere in the terms and conditions that we all scroll through and tick. So we know there's a risk with these things, but there is also a benefit from using them. And Cambridge Analytica and other examples, it didn't stop people using these processes. And the status quo isn't acceptable. So what we need to do, and Steve's absolutely right, the framework for research is both more reliable and heavily regulated, because we don't need to know the personal information to do the research. It's different when you're doing healthcare. We need to see if it actually makes things better. And that's what the research is for. And if it does, if it saves lives, if it reduces delays, if it improves outcomes for patients, then that's the benefit against which you have to balance risk and cost.
So there's the other end of this in terms of digital health. We've talked about, the general world. So I've got two wearables today. So I've got a watch, which is measuring stuff, and I've got my phone, which is measuring stuff all the time. And I've got kind of apps on my phone which are collecting everything. So I never read the terms and conditions. It always says, do you agree? And I go, and you look at it, and it's like 20 pages long, and you go, oh yeah, I'll just agree.
Just scroll through that.
So scroll through, hit the I agree, and then suddenly my phone is collecting everything about me and sending it off to someone that I don't know. And they have everything about me. So there's stuff about me all over the place. Now, we are quite accepting in doing that, in sending that off. At the other end, something about our very specific health conditions we're very uneasy about. So there's some some grey zone between one end and the other. And we want to connect the wearable end to the health end, because that wearable end is very, very important. In terms of behaviours, there's a direct correlation between your health and how physically active you are. It's kind of nailed on. And how physically active you are is an indication of other things in your life, how much you eat, how much you smoke, how much you drink, and they're all interrelated. People that start doing more exercise in January tend to drink less, smoke less, eat better, and January is a kind of a case in point. A lot of those people fall off the wagon by the end of January, it has to be said. But generally, people who have better behaviours in one compartment have better behaviours in another. And that affects your health. And of course, your health affects how physically active you are. So it all goes round in a circle. So we need to know about all of those things. And, there are very specific ways of changing people's behaviours. There are psychologists that have worked on behaviour change for years and years and years. And we do kind of need a massive behaviour change approach, and wearables is one part of that. So you give someone a wearable and say, we're going to count your steps. Okay, suddenly someone going, oh, I better do more steps. As soon as you give someone like that, and then once they don't want to do many more steps, they'll take it off. So you've got to be careful with that. So there's a way of using those wearables in a really positive way that changes people's lives positively in a meaningful way.
I wonder if you say it's 10, 20, 100 years, however many, and we've figured this out. So we've connected wearables to healthcare data. It's all really slick. Can you give me an example of how that's going to help me as a patient, for example? If something goes wrong, how does that connectivity help me?
Absolutely. So sometimes medicine's like trying to find a needle in a haystack. And because we all get breathless from time to time, we all have chest pain from time to time, and we all have to work out, well, okay, this might be nothing, or it might be cancer or heart disease. Do I go and see my doctor? And if you make the decision the wrong way around, then the consequences can be difficult. And then that just happens again and again in the chain. You go and see the doctor, and that doctor has to work out, okay, could this be cancer, or could this be heart disease, or is this nothing? Is it going to settle down? So you have to find a way to recognise the needles in the haystack more quickly and efficiently, because we know we get it wrong very frequently. I mean, unfortunately, every day you read the newspapers, you find someone who has sought attention again and again and been incorrectly reassured, or indeed didn't seek attention and turned out too late. Once you have the information that you know what a needle looks like compared to a piece of hay, then things would be much more accurate. And if you just improve the performance at each of those decision points by a few percentage points, then the cumulative benefit is huge. To take an example, and when we were talking about the experience thing, right? I mean, one of the difficulties is you've got to get yourself in front of someone who's got enough experience to recognise the thing that you've got. And if the thing that you've got is rare or less common, then it can take an awful long time before you're in front of someone who says, it is this. And there are types of heart disease which are really quite obvious to people who know how to recognise them, but it takes people 2 years to get a diagnosis from the point of symptoms to the point of diagnosis, because they've gone back and they've been told they have asthma, or they're told they have other issues, until the penny drops, because the experience is somewhere else, right? So we do need to be able to digitize that experience so that we recognize the patterns of a particular condition earlier. And this isn't any criticism of primary care. I have no idea how primary care sees the huge range of things that they do, and they are very good at it. But it's a challenging information task to recognize every possible condition at the earliest possible point, and that does need to circumvent this issue of where it really only works unless you see someone who's able to recognise it.
I think one of the things that, going back to primary care, I see my doctor putting copious notes in there, and I can see some of my notes on my record. I can look at those records, and I've got cholesterol tests and blood tests and all sorts of things over the years. I didn't remember having that test or whatever. But you go to the GP, and I was speaking to a GP the other day, and they said, why we say, how are you, at the beginning? I said, no, why? She goes, because the answer to that tells us a lot of the reasons why you're here. So if you say, oh, yeah, well, my husband's not so well, and da-da-da-da-da, and then you go, so what do you want to talk about? Oh, well, I've got, I'm not sleeping very well, this, that, and the other. And so the doctor's going, okay, well, let's put these things together. Husband's not well, anxiety, da-da-da-da-da. So that kind of experience that GP would have, which is figuring out what's the real thing that's going on, with wearables, possibly not for my 80-year-old mother, but me in 20 years' time, I'll still be wearing my wearable when I'm 80. The doctor, I've heard this as an example, that someone went in and the doctor was asking, what's your sleep like? And this person got out their wearable and opened up the app on the phone and went, oh, that's my sleep pattern. I'm only getting half an hour at a time and waking up. And the doctor kind of went, oh my God, okay, right, I think that's your issue. We can't do anything else until you get that sorted, because you cannot function on that kind of sleep pattern. So although the issue that the person had gone in with was something completely different, that was only an outcome of this poor sleep pattern. So those kind of daily life things, I think, are really quite important. We can get that into the health record and into the conversation, as Tim said.
The other point that you've just made clear is how much of medicine is a time series or a time course issue. So, okay, you might feel lousy today, but how long has that been going on for? Is it a day, a week, a month? None of us are very good at actually keeping track of these things. I mean, thank heavens, really. I mean, if you were writing a diary of all your symptoms every day, then that wouldn't be a great way to live your life. But I'm struck how, I couldn't tell you what I had for breakfast yesterday, right? So telling you how long I've had back pain or chest pain or breathlessness, and whether it's getting worse and at what rate it's getting worse, all of which are really important factors in trying to work out, okay, are you the needle in the haystack, or are hugely important. So at the moment, to get the most effective healthcare, you really need to be able to report your symptoms and how they change over time, potentially years, really accurately. And that favours articulate people who probably got too much time to think about these things. Whereas if you could just measure that passively and they say, I think I've got a problem, and you look back, and as you say, the sleep's really bad and it's been getting worse over 2 years or 2 weeks, or it's always been like this. This is all important information that's very, very hard to just keep on track of.
I'd be a terrible witness in a court. What were you doing on the night of the 12th of whatever? I have no idea. Absolutely no idea.
Yeah, I've seen a doctor recently, and I realised I am a terrible patient. I don't know. And they said, you came to see us 10 years ago. I said, I have no recollection. Are you sure? I had this test. When was that? I think it was 5 years ago. And they look at the record. That was 15 years ago. I said, I'm sorry. Yeah, that makes sense. Yeah, that's right, because I've moved house since.
And that's a natural thing, is it? Who's keeping track so meticulously, like you say? So I suppose... you're saying that things like wearables can do that for you. That's keeping the data, like your sleep example, for example. That that's taking care of monitoring all of that stuff, so that we can be free to think about other things, live our lives. And it sounds a little bit like that's what you're saying about how being connected with all this data will help GPs of the future, for example. I don't think you're saying it's about replacing a GP with a chatbot, for example. It's just about freeing up the GP's kind of time and space, because they have all of this information about you to hand without having to ask you and go through that whole massive conversation.
When a GP, you go in, a GP's like staring at your notes, and these can be pages and pages long. For a doctor to distill the most important bit of information from all of those results, it must be really hard. Now, we have meetings now where something is recording our meeting and gives us an overview at the end of the meeting of what happened in the meeting. And that is really, I find that quite scary. So I've been very careful what I say in those meetings. But that, if it's able to do that, is there something that's able just to go, here's a quick snapshot of this patient. These have been the most common issues over the last whatever. Just to help the GP go, okay, that kind of makes sense, or I disagree, or and we've got the caveats are, models are only models, that they're not reality. So even the most sophisticated models have error margins. So we've got to be careful of that we've always got kind of a bit of kind of skepticism of, do I really believe that's true or not? Even to the things that people say, whether it was 5 years ago or 15 years ago.
I mean, models are not new. The doctor or the clinician or the nurse constructs a model of the patient in their brain based on what they read in the record and what the person's told, and it isn't an accurate assessment either. It can't possibly capture the complexity and the nuance of a particular individual. It's amazing in some ways that with such little data we do as good a job as we do, but it's a long way away from how good things could be if we had more information. I mean, also, to be clear, we're not saying everyone must wear a wearable despite what they think and they must collect their data. I think the likelihood is, if you biobank your data, as it were, later on, the ability to show your doctor that, okay, this is how much exercise I was doing before. I was doing 15,000 steps a day a year ago, and now I can only do 2,000 steps a day. For example, that would make me go, oh, okay, you need some looking at the moment. It's a simple way forward. So you can see the same things with heart rate or breathing rate, and I mean the new technologies, the things that they can record. I mean, it's not rocket science. If you can't get out of your house, which your phone will tell you, then something's not right. And every night in A&E there'll be people admitted, and you look into think, how's you're in a really bad way. How long has this been going on for? It's been going on for months. It's going literally months or years. I've been sleeping downstairs because I can't get upstairs because I'm so breathless. It's like, well, why didn't we know about this before? We could have prevented this admission.
Yeah. I think we could talk about this for the rest of the day, couldn't we? There's so much to dig into. I'm wondering, maybe let's finish by telling me the one thing that you're really excited about for digital health for the next 10 years. What one thing gets you out of bed in the morning about digital health?
Gosh, blimey. For me, it's the integration of the system. So from someone out in the public, just going around and having their daily lives and getting some information about that, whether it be a wearable or from the phone or whatever, and integrating that with primary care and secondary care all the way through to the other end, so where it's stored, where we can make some meaningful decisions. So having that integration, because that's the elephant in the room. That's the bit that's really hard. And if in 20 years' time, 50 years' time, whatever, we look back and we go, we started that journey, I'd be really, really happy if by the time I, switch off my last wearable, if that, my heart rate goes to 0, if I've done some of that, that'd be really good. Yeah.
Amazing. Tim, what do you think?
I think that it's really exciting that so many people from so many different sectors are saying this is the right way forward. You speak to patients, and patients and citizens they have concerns, and they're very valid concerns, and they're reasonable. But the number of patients have expressed frustration that we are not yet doing this. Look, I've got my Apple Watch. Do you want to look at your data? 50% of doctors don't even want to look at the data, and indeed, there's some reasons why just because you got that data, you can't use it in healthcare yet, because we haven't done the research to prove it's helpful. So that's all the way from citizens and patients up to government organisations saying we have to do this. There is no other option. Again, it comes back to recognising the risks. We haven't really touched on health inequalities so much in this conversation, but we accept digital health done wrong can worsen inequalities, but the status quo is not acceptable. So we have to move this direction, and funders and patients and citizens and politicians and doctors and other clinicians and NHS organisations are all saying, we need to do this. So that brings together a coalition which is really powerful, and I love working with people from different backgrounds. I love working with patients and clinicians, and the common sense that they inject into the conversation will be what makes the difference between a gadget that doesn't get worn and a technology that actually improves things.
And actually, we'd just like to we haven't really talked about, partners and companies and businesses that we might work with. They're very good at making these things and selling these things. They're very good at that and making people pick them up and buy them. They're good at behaviour change. They will make me get my wallet out and buy this thing. So they're very good at that. And if we can harness all of that with the ones that truly work, then, that's a quick win.
Oh, amazing. Thanks both so much for your time. It's been a real treat to speak to you about digital health today.
Thank you. That was a lot of fun.
Yeah, absolutely.
Where can people find out more about your work?
Come to the website, South Yorkshire Digital Health Hub. Google that. Other search engines are available, and you will find us, or reach out, get in contact. Yeah. We have unusual names, so you can find us on the internet.
You'll find me on the internet
very
easily. Yes. Yeah.
Great. Thanks so much, Tim and Steve. Thank you.
Thank you.
Thanks for joining us for our inaugural episode of the Digital Health Hubcast. Here's my take on our conversation with Steve and Tim. Most of our health depends on lifestyle factors such as physical activity, sleep and nutrition. And if we have a smartphone or wear a smartwatch or other wearables, we're already collecting a plethora of data that gives insights into these lifestyle factors. If we could integrate this into our healthcare, then perhaps we could have better outcomes for patients and begin the shift to a more preventative model of healthcare. We also spoke about careful training and utilisation of AI models that could help healthcare professionals of the future better diagnose, monitor and treat disease. And connecting data sets within trusts could create a more seamless experience for patients and staff alike. I think put like this, it all sounds quite easy and idyllic, but these developments aren't without challenge. Not everyone wants to wear a smartwatch or can afford a wearable device, for example, something that we didn't talk about in very much detail. Moving forwards then, it seems like collaboration between patients, clinicians, academics and industry is key to the success here. And Tim's comment that we shouldn't accept the status quo seems like a clear call to action to go forth and innovate in this digital health space. You can find links to Tim and Steve's university profiles and a link to the South Yorkshire Digital Health Hub's website in the notes. And thanks for listening, and see you next time.